Good afternoon, everyone. My name is Sharon Rounds, and I'm the program director for Advance-CTR, and it's my great pleasure today to welcome everyone to the first Advance-CTR Translational Research Seminar for this academic year. We're really pleased today to have with us Christopher Schmid. Chris is going to be talking about personalizing healthcare experiments using N-of-1 designs. He's the director of the Advance-CTR Biostatistics Core and professor of biostatistics at the Brown School of Public Health. The Biostatistics Core also includes in its leadership co-directors Jason Mackin, who is Associate Professor of Surgery and Orthopedics located at Rhode Island Hospital, and Rochelle Rosen, who is Associate Professor of Behavioral and Social Sciences located at the Miriam Hospital. This year, we're going to be featuring our core leads in our first few seminars. So we're really, really pleased to have Chris here to kick this series off. So I will, without further ado, I'll turn things over to Chris. One point though, I want to mention for questions, if you could please enter them into the chat, and we'll be able to address them at the end of the presentation. And thank you again. Go for it, Chris.
Okay, thanks, Sharon. So I'm really happy to be able to give this first talk of the year. This is work that I've been doing with a lot of collaborators over the past 10 or actually more years on N-of-1 designs, which are personalized healthcare experiments. You can think of them like as a clinical trial for a sample size of 1. So I'm going to try to lead you through this. And before I start, I want to acknowledge all the collaborators I've had through the years. And I know that I've missed a bunch on this slide. So forgive me if I don't have your name up there and you feel it should be, but I've worked with a great group of graduate students at Brown School of Public Health, both in our master's and our PhD programs. Some of whom are now postdocs, some of whom are working in industry, and some of whom are still students. And then also a bunch of different research teams at various places, including Tufts, where I used to work, UC Davis, University of California, San Francisco, the University of Cincinnati, the National Children's Hospital, and Columbia. And these are all people that I have really enjoyed collaborating with and am still collaborating with. This work has been funded over the years by 4 different research grants from various institutes. And a lot of this work that you'll see is going to relate to the conclusions and the findings that we have come up with in these studies, some of which are actually ongoing. So this is actually work in progress as well. So here are the topics that I want to cover today. I want to talk to you a little bit about what an N-of-1 trial is and why you might want to use it. I'm hoping that there are a lot of clinicians in the audience who might think about using this in their practice. And I'll say right up front that if you are interested, please contact me. I'm happy to talk to you about how you might get this going. I'll talk a little bit about how these are designed, how they're analyzed, how you present the results, particularly since these are personalized trials. You need to present these results to people who may not know anything about statistics or about probability. And then I'll talk a little bit about some of the work that I've done with my students on combining N-of-1 trials, networks of studies. I'll provide lots of examples of work we've done and then talk about some of the issues that have come up in the course of our investigations. So what is a personalized trial and why might you want to do it? As I said, the basic way of thinking about a personalized trial is that it's a clinical trial for 1 person. And so you want to think about this in the context of the way we usually do clinical trials, which is in specialized settings, let's say at academic medical centers, with highly trained teams. And one of the drawbacks of those trials is often that they're not very generalizable outside of that very strict setting. So we would like to extend our research to non-traditional settings and even into everyday life, including routine clinical practice. And so we would like to be able to implement these trials both in a community setting, in doctors' offices, but also just in routine life. And I'll show you a couple of studies we've done where we've actually used the internet to survey people to find out how they feel about various interventions that might, for example, relieve their stress. And one of the nice things about these individualized trials is because they are directed at people, we can estimate individual treatment effects. So we can look to see how does this treatment work for a particular individual. And then we can look at how the treatment might vary across different individuals. So as I said, the usual kind of center-based randomized controlled trial gives you an average effect, but average effects may not and oftentimes don't apply to an individual patient. So for example, here I've given you a distribution of potential benefit among people in a population to a particular treatment. And you can see the center line is centered at 0.5, which indicates that there's a slight overall benefit in this population to this treatment. And so if we did a regular clinical trial, we might very well say that this treatment is beneficial. And yet you can see, looking at the distribution, that there's a large group of people here in the shaded region who don't benefit at all. In fact, their effects are so close to zero that we would call them not clinically significant. And then there's a large group of people over here to the left who might actually be harmed by the treatment. And so even while the treatment works on average, it may not work for everyone. And of course, we're all familiar with this through all the vaccine trials that have been done recently, that they work for most people, but not for all. So this work was motivated many years ago by a study that I did with a doctor, Don Goldenberg, at the Newton Wellesley Hospital in the Boston area, where we were looking at people with fibromyalgia, which is a chronic fatigue type of syndrome. And we recruited 19 people to do a study where they looked at 4 different treatments. One was fluoxetine, which is Prozac. One was amitriptyline. And then the other 2 treatments were a combination of the 2 and then a placebo. And while we found, as we expected, that people treated with the combination did better than people treated with either one individually, and they did better with people on the placebo, we also found, when we looked at a particular measure of improvement, that only 62% of those on the combination treatment actually improved, compared to, for example, 5% on placebo. So clearly, the overall treatment works on average, but it doesn't necessarily work for each person. And so we were sort of interested to see, well, is there any way that we can figure out who this works for? So the idea of an N-of-1 trial is it is part of a larger collection of trials called single case experimental designs, which are very common in the social science literature. And the idea here is that you come up with a personalized protocol for each participant. So think about an educational system where you're trying to teach a child who's maybe having trouble in math, and they go to some kind of training program, and you're thinking of a couple different ways you could teach them. And so you try a little study to see which one works best. Now, there are many types of these single case experimental designs. There's one called a multiple baseline, which is basically a type of stepped wedge design, which has become very popular in the clinical literature. The multiple baseline design, you have one crossover. You start on the control, you cross over to the treatment, but different people cross over at different times. And that's the way you kind of figure out how the treatment works. There's also the withdrawal reversal design, which is a multiple crossover, where you crossover back and forth multiple times. And that's really what an N-of-1 design is. And then there's the alternating treatment design, where you alternate back and forth between 2 treatments. Now, all of these designs can measure individual treatment efficacy, in contrast to traditional group or cluster randomized designs. But the other advantage of the way that we look at these is that you can combine these single case trials together in a multi-level structure to not only figure out what works for each person, but you can average across the people to get an average effect. And by looking at different types of people in different subgroups, you can also assess heterogeneity. And because you're doing this borrowing of strength across people, you can also often get better estimates for each individual, because if they're like other individuals, then you can borrow strength from those other individuals to get better effects. So the N-of-1 design, which is, as I said, a particular type of single case design, can basically be thought of as follows. If we want to compare two treatments A and B, we randomly assign them in periods, and oftentimes those are blocked so that for every 2 periods, you would get 1A and 1B in a randomized order. And you can see here we have a 3 crossover design with 3 Bs and 3 As. And the idea is you compare what you did in the A periods to what you did in the B periods. And you can have multiple measurements in each period. So for example, each of these periods might be a week long. And you can see that we would have maybe daily measurements. And those are the red dots. And you can also see that some of the periods we have more measurements than others. And that would be because people sometimes don't respond to a particular treatment. So we have multiple measurements, we have missing data, and we have comparisons. Now, there's some other complications to this too, because there's potential carryover, which means that when you start treatment B, treatment A may still be affecting you. You can think of that as like the half-life of a drug. You also have problems of trend, because if somebody's actually improving or changing over time, for example, if you're doing an educational program, people might be learning. And so people in the later periods might just do better than people in the earlier periods because they're learning. So basically, you have all these different possible complications to the analysis. Now, the N-of-1 design is not always recommended. There are certain types of conditions under which it works best. So first of all, you have to have substantial uncertainty about the effect of the treatment, which is true for any kind of trial. You want to have heterogeneous treatment effects, because obviously if it works the same in everybody, there's no point in looking at each individual separately. You want a stable chronic condition, and that's because you need some idea that the treatment is going to return, the effect will return to its baseline at the beginning of each period. Otherwise, the periods are not comparable. So think about a condition like COPD, where if people don't get their treatment, they're going to regress, and so you can change back and forth between treatments without this fear that they're going to resolve. Something like a heart attack, you would not be very good, because obviously that resolves, hopefully. The other thing is you want to have treatments that are basically short acting and happen quickly, because if they take a long time to take effect, then you're going to need a very long trial, which is going to become difficult to run. And I'll give you a couple of examples of ones I've been involved with where we've had that issue. There's also going to be you want to have a negligible persistence of carryover or treatment effect. You don't want the results to, for example, with a drug, if you had week-long periods, but the drug half-life was more than a week, then you would not really know whether the effect was to the crossover or to the previous drug. And you want to have obviously measurable, easily collected outcomes, because individuals are going to be doing this for themselves. Now, as far as the personalized protocols go, one of the nice advantages is that you can design your own study, or maybe in concert with your doctor. You can select which outcomes you want to study. You can select which treatments you want to look at. You can also help with the data collection process. For example, you might like to collect the data in the evening or in the morning. You're not set by a protocol. And we oftentimes will try to implement these on mobile platforms, on, say, smartphones. So we need a simple interface to do that. And I'm going to talk about some of the examples we've had over the years of those kinds of procedures. So what are the key design elements in an N-of-1 trial? Well, as I said, we have randomized assignment of treatments, often in blocks of size equal to the number of treatments. So in the example I showed you, there were 2 treatments, so we randomized in blocks of 2. So let's say every other week we randomize, and then the following week you take the treatment that you didn't have before. We have replicated observations within and between periods so that we can assess how people are doing, what their variation is like. And that could involve deciding how many study periods you're going to have, how many measurements per period you're going to have. And obviously patients may not finish their protocol. So you want to have the design to be stable enough so that if they don't finish their protocol, you can still get some answers. So for example, you wouldn't want a trial where people took all the A treatments first and then all the B treatments, because not only would that be confounded with time, but if the person dropped out halfway through, you would never have any B treatments. And so these are problems that my students and I are working on to figure out what's the right trade-off between the number of measurements and the number of study periods, because clinicians always ask the statistician first, how many do I need? Then another thing you want to be aware of is the carryover effects, as I said. And so oftentimes we design in washout periods. And I'll talk a little bit about how you can design those in, but a washout period is basically a period of time between the crossovers where you don't measure the outcome and you let things return to baseline. And then finally, you can construct multiple outcomes here, and you can incorporate those into a decision model if you want. Now, with carryover, as I said, one way to avoid carryover is to design in a washout period where people are not on any treatment. But that might not be appealing, because if you're sick and you need some kind of a treatment, to wash out onto no treatment at all may not really be ethical. And the other problem, of course, is that the more washout periods you have, the longer the trial is going to take, because you have to add in these little periods of no treatment. And so that may compromise completion of the study, and it may also reduce the patient's willingness to participate. So what we oftentimes do instead is we set up a design such that you really don't have to have washout. So one is that you could apply biological considerations and either choose treatments that don't require long washouts, or you might analyze the biology to figure out exactly how long a washout period you need. Of course, with a lot of behavioral type interventions, it's very difficult to know, for example, if you're trying yoga, how long the effect of the yoga lasts into the next week. Or another thing you could do analytically is you could discard or downweight the first measurements you take after crossover. So for example, in one of the trials that I worked on, where we were taking weekly measurements over an 8-week treatment period, we discarded the first week's data in each crossover period to account for a washout. So here are some N-of-1 studies that I've worked on, and these are all the collaborators that I mentioned at the beginning, starting many, many years ago with a fibromyalgia trial that was sort of an outgrowth of that crossover trial I talked about. We looked at 58 people. They did 3 crossovers. Each treatment lasted for 6 weeks. We were looking at an outcome, which was the Fibromyalgia Impact Questionnaire, and we compared amitriptyline to a combination of amitriptyline and fluoxetine. Another study that is currently ongoing is a study of ADHD, looking at 300 individuals, 3 crossovers. Each treatment is 1 week in length. The outcome is time to sleep, and these are kids who are having trouble going to sleep because they've got attention deficit disorder, and the comparison is melatonin versus a placebo. A chronic pain study that I'll talk more about later. We had 98 people in the N-of-1 arm. They did between 2 and 4 crossovers of lengths between 1 and 2, and they tried various outcomes in various comparisons. This was a very patient-centered study because we allowed people to basically design their own trial. Inflammatory bowel disease is another one that we're just completed and we're writing up. 54 people randomized in 2 crossovers. Each period lasted 8 weeks. We had various outcomes, and we were comparing 2 different types of diets. A study to look at triggers of atrial fibrillation. It's actually more like 500 patients. There were 3 crossovers, each lasted for a week of treatment. The outcome was episodes of atrial fibrillation or a quality of life score. And we compared different triggers that people could try, for example, caffeine or alcohol versus none. Another study that we looked at was an internet-based study where we looked at daily mood, and we recruited about 260 people over the internet. They did 3 crossovers. They did 5-day treatment lengths, 30-day study, looking at various outcomes, including stress, and comparing various types of interventions, including meditation, gratitude journaling, and so forth. And then finally, this is a study I wasn't actually involved with, but was done at Brown. It was a sleep study where they looked at 42 people with 4 crossovers, and there were various recommendations for how to sleep better. And so these trials all had varying types of designs. So some other applications that have come up in the literature, and I forgot to put the references here, but I can add them and have Oaxaca send around the slide deck, So one is a study that a paper that I wrote a few years ago with a colleague, where we talked about how you could use this in kidney disease when you're trying to decide what kind of dialysis regimen to give individuals. There have also been trials that have looked at muscle stiffness for non-dystrophic myotonia, bright white light therapy, and sildenafil for Raynaud's phenomenon. So these have all been published in the literature recently as N-of-1 trials. And just to give you a sense of the breadth of some of them, in addition to the ones that I showed you that I've actually worked on. So let me say a little bit about the PREEMPT trial, which is the trial of chronic pain that I talked about. So this was a trial where we randomized people to either N-of-1 or usual care. And so if they were in the N-of-1 arm, they could set up their own trial. If they were in the usual care, they just had care by a prescribing, by the treating clinician. All these people had long-term chronic pain, and we did 3, 6, and 12-month follow-ups. And so there were actually 2 studies here. There was one study, which was the standard randomized trial of the 2 arms. And in that, we equally randomized people to the 2 groups. There were 215 people, and we compared them at outcomes at 3, 6, and 12 months. And the outcomes there were pain, quality of life, decision-making, satisfaction, trust, and adherence. And this trial, the design was published in 2015, and the results were published in 2018. And we basically found that the N-of-1 arm did a little bit better, but it wasn't statistically significant, partly because we didn't enroll as many people as we thought we were going to, partly because the effect wasn't quite as big as we were hoping for. In the N-of-1 arm itself, we used a mobile app that people could download onto their smartphone. 108 people eventually were randomized there. I think 98 completed. They tried various types of designs between 1 and 2 weeks. The trials went between 4 and 16 weeks, and they reported every day on how they felt on 6 different outcomes: pain, fatigue, drowsiness, sleep, cognitive function, constipation. And they plugged those into their phone every night, and they could sort of follow things over time. And then at the end, we had them meet with their clinician, and they went over their results and could make a decision as to what treatment they would like to take. And we've recently published an article which showed that people actually did gain some information from this, and some of them actually did change their treatment as a result of it. So these were some of the outcome measures that we looked at that people would respond to on their phone. You can see that many of these are Likert scales, they're categorical scales. And so the analysis is actually a little bit complicated because these were not continuous scales, and they're not really binary scales either. They're what we call ordinal scales. And so again, some of the research that my students have worked on is dealing with how to analyze these types of outcomes. The treatments that they chose were a wide variety, and they really could choose whatever they wanted. So some of them were already on treatments, and they could remain on those. For example, they might be on an opiate. They might decide to add something to that. So for example, they're on codeine, but they wanted to try yoga, or they wanted to try physical therapy. And so there were various combinations of these. And for the 98 people, I think only 5 or 6 people, had one particular treatment combination. We had probably 50 or 60 different ones. So it was really hard to combine the data together, but we got a lot of information about individuals. A second study that I've been working on, which just recently completed, is a diet study. We called it PRODUCE. And in this study, people were all doing N-of-1 trials. They started off on an usual diet for up to 2 to 3 weeks. And we called that their baseline. And then they were randomized to either start on a strict diet or a liberal diet. And then they alternated between the strict diet and the liberal diet. So there was no randomization here. They went in this particular pattern. And we looked at various different outcomes. So these are people with inflammatory bowel disease. So we're looking at things like their stools, their pain, their symptoms, and so forth. And one of the big parts about this study was it was funded by the Patient-Centered Outcomes Research Institute, PCORI. And so one of the things that PCORI likes to do is get patients involved. And so patients were very involved here. in designing this type of study. And so one of the reasons that we had these 8-week treatment periods was because people felt that it would take a while for the diet to have an effect, but they didn't want to make it too long because obviously the trial is already about 9 months long. And so one of the problems we had in this study was there was no randomization past the first period because the patients did not want to be on the strict diet for more than 8 weeks at a time. So the mobile platform that we set up here helped us to collect the outcome data. People would enter, their outcomes on a daily basis. It allowed us to track, whether they were collecting the data and how they were doing. We could send them reminders about their treatments when their treatment switched, or if they weren't entering information. They could review the collected data in real time. And then at the end, we wanted to present the results to them with graphics and tables that they could easily understand. And again, we developed those in collaboration with the patients, but it's very difficult to know, and this is one of the key ideas that we have to look at in the future, is how do you best present this information to people, when they may not have seen any math in a long time, or something like probability or statistics is a foreign language to them. So the interface here with the phone, we enrolled people through that, or we randomized them through that. We sent them prompts and reminders. We collected data from each participant. We automated the analysis so that once they entered the data, it was sort of run in I'll talk a little bit about some of the work that my students and I have done to develop those packages. And then we gave them feedback with some instructional videos. And that's, again, something that I think can be developed more in the future to teach people how to interpret these results. So this is what the setup looked like on your phone. You basically have a screen here which shows you the course of the trial. You do the baseline, the usual diet, diet period number 1, diet period number 2, and so forth. And then there was a little text here about what the usual diet is, and then it would tell you something about what foods were allowed in that diet. Then when they went to actually report their outcomes, so for example, for stool consistency, we showed them all these pictures of what their stools might look like, and they were to enter them. Now, since these were children, these were mostly entered by the parents, unless the children were teenagers. They could enter on their own, but they would enter one of these types of stools. They would enter the frequency, and then they would enter things about their symptoms, like, do you have the following symptoms often, rarely, sometimes during the day? And so we could then follow those over the course of time. Then the feedback at the end, they would get these graphs. They could pull up these graphs during the study to see, what their data looked like. And at the end, we would provide some analysis for them of those data. Now, in the chronic pain preempt study, we had a different way of presenting the results to people. So we showed them sort of line graphs. So the blue would be one period, and then the red would be another. Sorry, the blue would be one treatment, the red would be another treatment. You can see this person did blue, red, red, and then blue again. And you can sort of follow along here. And then we gave them various averages of how they did on each week, on each treatment. And then these were the different outcomes we were looking at, and we gave them bar graphs of how they did. Now, of course, for those of you who are used to thinking about clinical trials, one of the problems with these graphs is they don't really provide any estimate of uncertainty. And that's an issue that we're still trying to deal with, is how do you tell people, whether this difference is significant or not? Or, we found when we talked to people that they basically just compared the means, and if one mean was better than the other, they considered that to be an improvement. This is the way the data would look like. So for example, in the preempt study, this would be a pain score. This is their day of treatment, and each dot here represents a measurement. You can see that there's some missing days. And then there are various ways of analyzing the data. So for example, if you just fit means to each week, this would be the mean response on the red periods. This is the mean response on the black periods. And you can see that there's more pain on the red periods than the black periods. We would have to do a statistical analysis to make sure whether that was significant or not. We could also model it with trends. And so, this is modeling the trend over time. You can see that although the black treatment seems to be better than the red over here you can see there's clearly a trend where the things are getting worse and then getting better and then getting worse. And you could argue, is that due to the treatment or is that due to some natural process that we're not aware of? And so again, that's a complication that means that you have to study the person enough to be able to disentangle time trends from the actual treatment effect itself. So in terms of the statistical analysis, and I don't want to spend a lot of time on that today because I'm really focused more here on just a conceptual understanding, but basically the data here are time series with a treatment factor. And so what we're looking at here is trying to describe this very simply. So one thing you can do is you can just have descriptive analyses with graphics. You can use basic statistics like a paired t-test to compare the treatments, or you can do some more complex modeling. For example, the time trend, you can incorporate time trends, autocorrelation, carryover, effect modifiers, and so forth. Again, I'm not going to spend a lot of time on that, but I will show you some examples of things we've looked at. So there's always got to be one slide for formulas for those who like formulas. So here is the model for a single trial. Yj here is the outcome at time j for a single person. This is the mean. This is the treatment effect. This is the treatment variable. This is some kind of time trend. And this is the random error. We can incorporate correlation in the random error. There should be actually a row here, some sort of correlation factor in front of it. I'm just noticing it's missing. And then there's some model for the variance. Again, don't worry about that. The key thing to note is that the model includes a treatment effect, a time trend, and correlation. And let us figure out how to do those calculations to get those numbers for you. Now, we actually use Bayesian models. And so some people have asked us, well, why do you use Bayesian models? Well, first of all, it's a personalized decision. People may have their own prior information that they want to input, so we can incorporate prior distributions. The Bayesian models allow us to interpret probabilities directly, which people often like to do. Standard methods typically require a lot more information to return a significant result. So you'll see a lot of times that the probability might be 80 or 90% and not 95%. We can use it to do more complicated things like make composite statements about multiple outcomes. We can combine the studies together to borrow strength, and it's easier to handle missing data. So for all these reasons, we've preferred to use Bayesian models, and we've developed software that can fit those. Now, what we've tried to do is to come up with an automated environment here where the modeling is done automatically so that people don't have to wait around for the statistician. And so this is implemented using smartphones. We use Bayesian models implemented in a couple of software packages, R and JAGS. And so those are done automatically for you in the background. Those return the posterior probabilities to the user. And you can then use that for a variety of tasks, such as comparing different models that you might want to fit. And we oftentimes will incorporate some kind of lag time if you want somebody to check through the results before you get it back to the people in the study. So here's what some of our feedback. Let me show you some screenshots of in the produce diet study. One of the questions was, did my stool frequency improve? And you can see here that the average number of stools per day is given on the usual diet, the modified diet, and the strict diet. And then at the bottom, there's some interpretation. So it says that the diet decreased your stool frequency by 0.1 stools per day compared to your usual diet, or 0.3 stools per day on the modified diet, and so forth. And you can decide whether having one fewer stool for every 10 days is worth it or not to you. We don't try to make that interpretation. We just provide the information. And then there are some graphs that we use. Unfortunately, these didn't come out the way I'd hoped. But for example, the likelihood that the diet is better than your usual diet. So over here, you see that's 34% chance that it's better, which means that there's a 66% chance that it's not better. What I wanted was to have the probability that's actually worse and the probability that's the same. We'll get that on the next iteration. But you can see that right here, the modified diet seems to be better than the baseline diet. There's actually a 2/3 chance And it's very unlikely that the two are different from each other. And again, you can use that to interpret it the way you want. In the pain study, we used a different type of response. These were more for the doctors, but also for them to look over with the patients. So this is the sort of standard kind of estimate in a confidence type interval. This is a Bayesian credible interval. So this is your best estimate of the treatment difference. The dark red means that treatment A is better by at least 20%, which was thought by the clinicians to be a significant effect. Over here, treatment B is better by at least 20%. And in the middle here, A or B are better, but by less than 20%. And so you can sort of just scan this and say, well, in most of these cases, it seems the treatment A is better, but only for drowsiness is it actually substantially better. Or you could look at it this way and look at the probabilities. So for example, for pain, there's about an 80% probability that it's just trivially better and a 20% chance that it's trivially better on treatment B. Whereas for drowsiness, you can see it's almost all dark red, which means that there's a strong probability, almost 100%, that it's clinically better on A. And you can see that over here because this uncertainty region is all in the clinically significant area. In the diet trial, we presented things slightly differently, and this is actually more for the academic audience. So here we have the 19 people who completed the study, and we show their individual results. So black means that the first diet is better than the second diet. And in this particular case, we're comparing, let's say, the strict diet to the usual diet. The light area means that they're basically the same. They're within sort of the clinically non-significant region. And the light area means that the first diet actually worked worse than the second diet. So you can see here that for many of these individuals, they have a lot of black, which means that the first diet, in this case, the strict diet, is better than the usual diet. And for some people, it's unclear whether it's better or not worse, but for only a few patients does the diet actually seem to be doing worse. And then overall, we have here the conclusion across all people. You see that on average, it seems like the diet does work. But again, from the N-of-1, we can see that it works very well for some people and less well for others. These are people with Crohn's disease. These are people with ulcerative colitis. Then we did the same thing for the early completers. Again, the difference here is that there's a little bit less black, and that's because these are people who dropped out of the study, presumably because they weren't doing quite as well in the diet. And then finally, we have the withdrawals. And again, you can see here, these are people who didn't even finish 2 periods. They dropped out very early. And again, what's obvious here is that the overall average is that there doesn't seem to be any benefit. So again, there's about 20 people in this group, about 10 in this group, and about 20 in this group. And so this splits out pretty well as to who actually benefited from this trial. We also looked at inflammation. So that's measured by fecal calprotectin. These, again, are the full completers. Because we had only one measurement per period, we actually show the raw data here. And so the pluses are the baseline, and then these other figures are where they were on one of the crossover periods. And the key idea here is that they did better. Their inflammation decreased between the baseline and later on. So for example, overall, this is the average effect on the baseline, and these are the average effects on the 2 diets. And we did the same thing for the early completers. And you can see here that there are some individuals who, overall, there's not really much of a difference on these early completers, although there's a couple people who did improve quite a bit. And then we have the withdrawals, where again, there's very little effect and there's much less data because these people dropped out early. So that's basically how we look at each individual's data. I've sort of referred to this combining into an average. And the way we do that conceptually is we treat each N-of-1 trial as a study. And if you're familiar at all with meta-analysis, you know that we can combine data across studies via meta-analysis. And that's what we're basically doing here. We get a population estimate of the treatment efficacy, and we get improved estimates for individuals by borrowing strength. So D is the overall average. Delta I is the effect for each person. And this basically, this delta I is a compromise between just using D for everybody, which would be complete pooling, or using just the individual's observed response which would be no pooling at all. And the idea here is that the overall the estimate for each individual is this delta I is weighted toward your own data if you have a lot of data, but it's weighted toward the average if you don't have much data or if your data are very heterogeneous. And so this helps you make a treatment decision, and you can include covariates for regression models. You can include terms for carryover and correlation. And if the treatments are different, if you have more than 2 treatments, you can form a network of treatments, so-called network meta-analysis. Again, I'm not going to get into the details of this, but there are some papers you could read, and we're certainly working on some of our own at this point. The final trial design I wanted to show you was the trial for the triggers of atrial fibrillation. Now, this is called the iStop AFib study. And here people were randomized either to do a trigger test or to daily tracking. And so you can see that people in the daily tracking tracked their triggers for 10 weeks, just doing nothing, but tracking. And people in the trigger group tried an N-of-1 trial for 6 weeks. 3 of the weeks they did the trigger, 3 of the weeks they stayed off the trigger. And then they had a 4-week period, a follow-up. And then at the end of 10 weeks, we measured how they were doing in the 2 groups. So again, this is a sort of 2 trials and 2 studies in one. We have the comparison of the N-of-1 arm to the tracking arm. And then we have people who are doing triggers. And after this 10-week period, both groups could do optional triggers if they wanted to, multiple triggers. So for example, somebody might think, well, maybe coffee is triggering my atrial fibrillation. So I'm going to stay off coffee for a week, but then I'll drink the coffee and I'll do that 3 times and see how I do. Or maybe exercise is triggering my atrial fibrillation. So maybe I'll run 1 week and I won't run another week. And so we have this whole set of studies that people did as N-of-1s, and we could combine those to get individual results and summary results. And so again, there's an extension of this model to multiple trials. Again, I'm just going to very briefly go over that. We now have treatment effects that differ by person, and we have these trend terms. We have potential carryover that we can measure. We have correlation that we can measure, and all of that is measured in a single model. And what we're working on is how you do this. So, do it for continuous outcomes, count outcomes, binary outcomes, ordinal outcomes, and so forth. So again, I don't really have time to talk about that in detail. So for one of the triggers, alcohol, using an intent to treat analysis where they're self-reporting their atrial fibrillation in the primary period, meaning the first 10 weeks, these are the individuals who did the alcohol trigger. So this person, on the 18 days that they tried the trigger, they had 6 events. And on the 12 days where they were off the trigger, they had 3 events. And we can do an analysis of each person, and we can compare the odds of a trigger on versus off. And you can see these odds ratios. And then at the bottom, you have a summary estimate. And for those of you who are familiar with meta-analysis, this is just a standard forest plot. And then over here, we have the probability that the odds ratio is greater than 1, i.e. that the alcohol triggered their atrial fibrillation. And so you're looking for high probabilities here. And you can see that while some of them are much greater than 50%, none of them is that close to 100% because there really isn't enough data to figure this out. And then the final point I just wanted to go over is the idea of the network meta-analysis. This is a big topic. The basic idea is if you want to compare more than 2 treatments, but you have studies that may not compare all the treatments at once, you can combine the direct estimates of the effects from individual trials with indirect estimates from looking at the trials together in a way that respects randomization and allows you to make these comparisons. And so there's a large literature on these now, and you can rank the treatments and so forth. And so I'll sort of take you through what one of those looks like very quickly. So in the N-of-1 structure, this might be the N-of-1 trial for the first person. They're comparing A versus B. And you can see here that this person can look at the comparisons of A versus B over 3 crossovers. This person did A versus B over 2 crossovers. This person did B over C. And so what you might be interested in is, well, what can I say about B versus C if I've only got one trial that did B versus C, or maybe only a few? And the idea is that, well, under certain assumptions, if you combine the A versus B with the A versus C, since they were both compared to A, you can get an indirect comparison of B versus C through that. And so there's the idea here is that there's a complete treatment set A, B, and C, but not every person gets all the treatments. And so we set up a model for doing that. And since I'm running a little short on time, I'm just going to very quickly show you how this would work in the iStop AFib trial. So somebody might do a comparison of caffeine with nothing, and then they might do another study of alcohol with nothing. And now, since they've done all three of these treatments, you could think about there's an indirect comparison between caffeine and alcohol, because if they did much better on caffeine than on none, but they did worse on alcohol than none, then you might think that they're better on caffeine. Somebody else might have done a study of exercise, and somebody else might have done a study of sleep. And this person who did the study of sleep might also have done a study of caffeine, and so they have an indirect comparison. So now you have comparisons within people of this group and this group of treatments. And now if you put them all together and make certain assumptions into a network, you can compare all 5 of these together. And so that's what we've sort of done in our analyses. And so again, there's a model behind it. That's all you really need to know. The model allows you to make all these comparisons. I can give you references to these if you're interested in the models. In our study, we looked at comparing all these different types of triggers, and you can see that basically they're all pretty much the same using the intent to treat analysis here. The alcohol seemed to trigger things a little bit more than the others, but it's not quite significant. The overall probability that alcohol is a trigger is 89%, which you might think of as a signal. Most journals wouldn't allow you to probably say that in your abstract, but maybe having had this signal, you'd go out and study alcohol a little bit more. So let me just say a little bit about some of the current work that we're doing, particularly the students at Brown, where we're modeling the categorical outcomes using generalized linear models. We're using some simulations to determine the operating characteristics of these parameters. So, when should you use which model? And I haven't talked at all about the modeling, so we'll just leave that as a black box. As I referred to earlier, how you choose the right number of people to study and the length of each crossover period so that you can optimally allocate the effort to get the information you need, how you would handle missing data, how you would put the software into apps, and how you'd improve the computing so that things go a lot quicker. And then some future work that we've kind of thought about is hybrid models when you have summary data available for some individuals and studies, but not for others. So you might, for example, want to combine a regular RCT with an N-of-1 type study. So I might know something about triggers from another study and I want to incorporate that somehow. There are various adaptive designs where you can change the design as you go along. There are various real-time systems you could build, so you might be able to do a little trial on your phone. And then obviously very different kinds of patient and mobile user networks are going to be necessary here in sort of informatics. So the conclusion here is that N-of-1 trials can be a useful tool for personalizing treatments and discovering individual effects. You can combine the trials from different people to inform, to get average effects and improve predictions for individuals. You can embed them as part of a larger network to inform treatment comparison. And obviously, as always with research, we need to do more work and we need to collect more data to get more precise answers. And let me stop there. So I left about 10 minutes for discussion, which is what I was trying to do. So for the first time ever, I finished on time. So I'll turn it back over to you, Sharon.
Okay, thank you so much. It's really fascinating. I would ask the audience to please enter your questions into the chat, and I'll sort of start things off with 2 questions. One is, if you're presenting data to participants, I'm wondering, have you ever considered getting the design experts at the Rhode Island School of Design engaged in developing people-friendly formats?
Yeah, that's a great question. And I actually submitted a grant a few years ago to PCORI to look at precisely those kinds of questions. And I didn't involve RISD at the time. I probably should have. Unfortunately, the grant didn't get funded. I'm still, hoping to put that back in, but I think that's a great idea. I know there are people working in my field in presentation in terms of, how do you get the idea of a probability across to people? But I think we could get a lot more creative in the ways that we display information. So I think that's a great suggestion.
They might well be very interested.
Oh, of course. Yeah. Yeah.
And my other question is blinding. I didn't hear the blinded word here.
Right.
And how does that, speaking from I guess from a theoretical point of view, how does that affect the lack of blinding? How does that affect the validity of the conclusions?
Well, so as with any trial, sometimes you can blind and sometimes you can't, right? So you typically want to blind if you can, so that there's no kind of expectation of effect that might bias your estimates. So in some of the studies that we've done, like for example the diet study, there's really no way you could blind there. With the trigger study, there's no way that you can blind because people are doing it on their own. With the pain study, again, it's hard to blind if you're, to blind between yoga and a pill is kind of difficult. But there are definitely other studies where you could. So for example, the amitriptyline study that I talked about early on, you could definitely blind that if you can, use a pharmacy to create the pills. Of course, some of these drugs have side effects that become obvious. So, if a drug has a side effect, you might know whether you're on it or not, but you should build in blinding as much as you can. It's just that when people are designing their own studies, it's kind of hard to do that sometimes.
So Katie Sharkey has a terrific question in the chat, thanking you for helpful presentation. And can you talk about the difference between N-of-1 studies and case studies?
Yeah.
Excuse me. She goes on to say she's published a few case studies, but they were retrospective. Specifically, I'm wondering about IRB approval and also reluctance of certain journals to publish small samples.
Right. I mean, that's a great question. So first, let me get to the IRB approval, and this is actually covered by a chapter in our AHRQ publication. IRB approval is required for research, and so to the extent that an N-of-1 trial is just for personal treatment, for example, the usual example I give to people is you go to your doctor with back pain, and the doctor says, well, we could try a couple of different things. That's not actually research. That's just being directed at individual treatment. So you wouldn't need an IRB for that. However, if you're going to combine a bunch of N-of-1 trials together to figure out what's the best way to treat people with back pain, then you might need to go to the IRB. But there's a nice discussion in that pamphlet of those issues. Now, the difference between N-of-1 studies and case studies is that the N-of-1 study usually is a design study. The case study, as I think about it, is more sort of an observational thing. So you might follow somebody who's got a particular syndrome, and you might have tried different things with them, but you might not have done it in a sort of a scientifically rigorous manner with randomization and blinding and blocking and all this kind of thing. There are observational N-of-1 studies, so there is a little bit of an overlap there, but I would say the main difference is just this concentration on design to control for bias. But certainly some case studies could kind of morph into N-of-1 studies, I think.
So, and if you, when we get a chance, if you could put the link to that paper in the chat, that would be, or we can disseminate it to.
Yeah, there's, I don't know whether we're disseminating the slides. I'm happy to do that. That one actually is linked at the bottom of one of the slides, but I can certainly put together a set of papers if people are interested in some of these. As I say, some of the ones I'm working on, we're still in the process of writing up. So those actually haven't been published yet.
Another question is, there's a striking resemblance of this to clinical practice, particularly in treating chronic conditions. You tried this, you tried that, you tried the other thing. are there lessons to be learned for practitioners in how to go about that kind of management of a chronic condition?
Right. I mean, we did do some surveys of people in our pain study. We did some focus groups. So just a shout out to Rochelle if you want to do focus groups. We actually did some qualitative work here, and we found that people actually found it was easier to talk to their doctor when they were participating in this sort of dual endeavor, right? Where they're both working on designing the study. And so a lot of people's response was like, it was great. I actually had data that I could go to my doctor and say, I felt really good these days, but I didn't really feel, well these days. And so I think just the collection of data is sometimes very helpful in terms of clinical practice. So that's sort of one point. Another point is that a lot of times patients, I think, just kind of default to the doctor, figuring the doctor knows best, which is true in terms of medicine, but may not be true in terms of their personal lifestyle and ways that these things work. So you might find, for example, that a certain treatment tends to work, but you don't tend to take it very often because it's just difficult to remember. So things like that are nice to discover.
And then the question is, what about bias against small samples in publishing?
Yeah. Well, that's definitely always a problem. And in fact, for our diet study, we've tried a couple of places to publish, and it's been turned down, I think, partly because, I don't think some of the reviewers understand what an N-of-1 trial is and how it's different from an RCT. And, they're seeing a sample size of 50, and then they will say, well, only 20 of your 50 completed. So how can you conclude anything? And, my response to that is, well, yeah. So what that basically shows is that there's 40% of people actually responded to these diets. And so why don't you try the diet out? And if they respond, great, keep them on it. If they don't respond, take them off it and try something else. But that doesn't mean that it's a useless study just because, people dropped out. That's basically people voting with their feet and saying this doesn't work for me. So it is something we're going to have to struggle with the small samples. I think we're just going to have to, make sure that these studies are well designed and that we get the message out there.
Great. And Katie comments that in 2 of her case study publications, her patients have been co-authors. Have you done that?
Yes, in our diet study, we do have patients as co-authors, and I believe we did in the all the patients who are on our steering committees have been part of that. So we actually worked with 2 large patient-centered healthcare networks, the Healthy Heart Network for the atrial fibrillation study and the Improved Care Now network for the diet study. And both of those are national organizations. And so we involved leaders of those organizations as authors in our papers. And that's where we got a lot of great feedback from them.
Great. Okay. Other questions from the crowd? Well, with 1 minute to spare, I'm not seeing any other questions. I just want to thank you for, we all want to thank you for a very, very interesting presentation. And we all learned a lot.
All
So
right, thanks, Sharon.
Great start to the year.
All right.
Bye-bye.
Enjoy lunch, everybody.